All right, this is the physiology lecture for chapter 15, which is on blood flow and the control of blood pressure. I know we've already covered part of this chapter before we went on our 2-week spring break, so I'm just going to go ahead and do the whole thing starting from the beginning and hit the highlights, and let's get the basics down. I'm not going to try to read everything to you because I'm taking it on faith that you guys are reading the text on your own, or at least reading through the PowerPoints on your own, and you already have the exam study guide. So I'm just going to hit what I think are the highlights and hit the picture because I'm a visual person. All right, on this picture here, it shows the systemic circulation and also the pulmonary circulation. If we start on the left side of the picture, we're going to work our way around clockwise. If we start on the left side of the heart, blood goes into the left atrium, then it goes through the bicuspid valve into the left ventricle. When the left ventricle pumps and contracts, it pushes the blood into the systemic artery, starting with the aorta. The aorta is the largest of the blood vessels that are systemic arteries. And then as blood flows through the systemic circuit, it diverges and goes into smaller and smaller vessels. The arteries are also known as vessels of a pressure reservoir. That means that arteries hold a certain amount of pressure in order for the blood to flow. If you remember back to the cardiovascular system on the last PowerPoint, fluids and gases both flow due to a pressure gradient. So the heart creates a pressure gradient. And as blood vessels move through arteries, the pressure goes from high pressure to low pressure. Okay, so again, I want to point out that the arteries, are known as a pressure reservoir. All right, as we continue down through the circulation, we go into the small arterioles. Arterioles are smaller arteries. Whenever we look at the tunics of the arterioles, they are thinner than the arteries, and they also have really thick muscles. The arterioles are also known as vessels of variable resistance. They're called vessels of variable resistance because they have the ability to vasoconstrict and vasodilate. The more the vasoconstrict, they increase the resistance of the flow through the system, and it increases the pressure. The more they loosen and dilate, called vasodilation, they open up and then increases the blood flow and it lowers the pressure. Anyway, arterioles are known as vessels of variable resistance. After the arterioles, blood goes into the capillaries. In the systemic capillaries, we have an exchange of nutrients, including gases and also nutrients like glucose and lipids, fatty acids, and also amino acids. So the nutrients go into the tissues, and then the wastes leave the tissues and go back into the circulation. After the capillaries, where we have an exchange, they go into venules. Venules are small, thin veins. Now, if they need to, venules will also exchange nutrients and gases as well as the capillaries, but the capillary beds are the main vessels for exchange, but venules can help out if needed. All right, the venules are going to converge, and they're going to get bigger and bigger until they become veins, and veins are large compared to venules. The veins carry the blood back into the right side of the heart, starting with the right atrium. The three main vessels go into the right atrium being the superior vena cava, inferior vena cava, and also the coronary sinus. And now I would like to point out that veins are also known as vessels that are a volume reservoir. What does that mean? Well, that means that most of your blood at any given time are going to be found in the veins. About 60% of the 5 liters of blood in your body are found in the systemic veins. So they maintain most of the volume. So remember, arteries are the pressure reservoir, arterioles are variable resistance vessels, and then veins, they are the volume reservoir. Okay, on this slide, you guys can read this. I don't need to point anything else about that. It's pretty simple. It's more of an anatomy review. Now on this slide, I do want to point out where the difference in the thickness of the tunics are comparing the artery the arteriole, capillary, venule, and the vein. I think we've written this down already weeks ago when we had this in lecture. On this side over here in this picture, although the wording above it is kind of screwed, but we can definitely tell what we're looking at down here. The taupe colored right here represents the fibrous layer of the vessel. The red represents the smooth muscle layer of the vessel. Blue represents the elasticity of the vessel, and then purple being the endothelium. If we compare the different vessels between the large artery and the arteriole, and then the capillary, and the venule, and the vein, the arteries, the large arteries, have the most elasticity component to it, which is why the blood vessels are the pressure reservoir. The higher the elastic content, then the more pressure it can generate whenever the blood flows through it. If we look at the arteriole, look, there's no elastic component to it, but there are muscles as well as an endothelium. And if we look at the capillaries, it is an endothelium only. This is also known as the tunica intima. And then the venules, when we get to larger vessels, they have the endothelium, and they also have the fibrous connective tissue on the outside part of the tunica externa, no elasticity to it, and then there's also no muscle to it. And then we get to the larger veins. The larger veins have all four components. It has the endothelium, it has the elastic component too, but not as much as the larger arteries. And then it also has a muscle, the smooth muscle layer to it, and then the fibrous connective tissue. The tissue layers that are the thickest in the veins are the outer layer, the tunica externa, or the fibrous tunic. And then the thickest layer in the large arteries are going to be the elastic components to the muscle. On this slide, I just want to point out the pericytes. We're going to look at pericytes again when we get to the urinary system. But pericytes are cells that surround the capillaries. The higher the concentration of pericytes, the least permeable the vessel is going to be. But pericytes can help control the rate of exchange between the capillaries and the tissues that surround it. If we look at this picture right here, it shows you the capillary bed. When we look at the capillary bed, there is one arteriole that goes to the very center, and it's called the met arteriole, and it's represented right here. That would be going into the met arteriole. Now, there are no muscles in the met arteriole, but there are sphincters called precapillary sphincters. We can see them right there, right there. And the met arteriole sphincters, the precapillary sphincters, control whether blood goes into the capillary bed or not. If the sphincters are open, which is what they're showing in this picture right here, if they are open, then blood goes into the capillary bed and it delivers the nutrients to the tissues. If the precapillary sphincters are closed, which is what they're showing in this picture right here, then the blood will just go straight through the met arteriole from the arterial end to the venular end, bypassing the capillary bed. Now, why would your body want to bypass the capillary beds? It has to do whether you're in the parasympathetic or the sympathetic nervous system mode. If you're in the sympathetic nervous system mode, fight or flight, then blood is diverted away from the kidneys, away from the digestive organs, and diverted to the lungs, diverted to skeletal muscles. Let's talk a little bit about how blood gets back into the heart, because there are three mechanisms in place to help blood return back to the right atrium. One of those methods is valves. Veins have valves, and valves prevent something from going backwards. There are valves in the alimentary canal to prevent foodstuff from moving backwards, and there's also valves in the veins, and they prevent blood from flowing backwards. And we can see them right here in the lower limb in this picture. All right, the other methods are mentioned on the next slide. On this slide here, let's take a look at it. This sentence right here, venous return aided by valves, that's one method. Then we have the skeletal muscle pump That's another method of assisting blood flow back to the heart. What does that mean? That means as you flex and extend the muscles in your limbs, it helps milk the blood or push the blood towards the heart. And then we have the respiratory pump. And we're going to look at the respiratory pump when we get to the respiratory chapter. But basically what that means is as we increase and decrease the pressure inside the thoracic cavity will increase and decrease the flow of blood through the blood vessels in the thoracic cavity as well. All right, other things we want to look at this slide because there are some really important things. We have pulse pressure. You have to be able to measure pulse pressure. What is pulse pressure? Well, pulse pressure is whenever you take systolic pressure and you subtract the diastolic pressure. But what is blood pressure? Blood pressure is a reading that measures or estimates the pressure in major arteries during ventricular systole and diastole. Whenever the ventricle, and we're talking about the left ventricle specifically because we're looking at systemic blood pressure, whenever the left ventricle contracts and pushes blood into the systemic arteries, it creates a pulse. If we measure the pressure inside of the arteries during ventricular pressure, that would be the systolic pressure. And then, as the ventricles are relaxing during diastole, the arteries maintain pressure because they are the pressure reservoir, and that would be the diastolic pressure. A normal blood pressure reading would read 120 over 80. That is a normal blood pressure reading. The 120 being the systolic pressure, 80 being the diastolic pressure. So if I ask you on the test, what is the pulse pressure, and I give you a reading of a blood pressure of 120 over 80, you would take the systolic pressure 120 and subtract 80, the diastolic pressure, and you come up with 40. So 40 would be the pulse pressure. So don't be surprised if you have to do that on the exam. Now let's talk about mean arterial pressure. The mean arterial pressure, represented by MAP, shows the driving pressure behind blood pressure. Remember, fluids only flow because of a pressure gradient. To find the mean arterial pressure, you have to know this formula. You take the diastolic pressure, and then you add 1/3 of the systolic pressure minus the diastolic pressure. Well, what is that? Systolic pressure minus diastolic pressure is the pulse pressure. So you take a diastolic pressure and add 1/3 of the pulse pressure. So if I ask you, what is the mean arterial pressure of a patient that has a blood pressure 120 over 80, we've already found the pulse pressure earlier. So you take the diastolic pressure 80 and you add 1/3 of the pulse pressure, which is about 13 1/3. It gives you a mean arterial pressure of 93 or thereabouts. Definition of anybody that has hypotension. Hypo means below or less than or lower. That means they have a mean arterial pressure lower than 70. Hypertension, which is high blood pressure, means that they have a mean arterial pressure of higher than 100. This chart is actually a pretty good chart, and it's a review of some stuff we went over way back in Chapter 5, and it's also a review of stuff that we went over in Chapter 14 over the heart. If we look at this very first one, blood flows if a pressure gradient is present. That is what this whole chapter is about. No pressure gradient means there's no blood flow. The heart creates enough pressure to create a pressure gradient so that blood flows through your system. Look at number 2. Blood flows from areas of high pressure to areas of low pressure. That is normal, that is natural. That's why the heart creates blood pressure that's pretty high at first. And then as blood flows through your system, the pressure gets lower and lower. Without that gradient, there would be no flow of blood. Number 3, blood flow is opposed to the resistance of the system. This goes back to Phys' law, if you remember that from Chapter 14, and also a little bit from Chapter 5, if you remember that. But Phys' law shows that resistance is related to or proportional to length times viscosity over radius to the 4th power. That means resistance increases as length increases. Resistance also increases as viscosity increases. And then resistance decreases as radius increases. So as the vessels vasodilate, it decreases resistance and blood flow is increased. Resistance opposes blood flow. Then we look at number 4. The 3 factors. This is Puiseuil's law again. 3 factors that affect resistance. We have radius of the blood vessels, length of the blood vessels, and viscosity of the blood. Now, which one of those has the greatest impact on the amount of resistance on the blood vessel? That would be the radius. The radius has the biggest impact on the amount of resistance because the length of the blood vessels will not change and viscosity of the blood does not change as well. All right, let's talk about what's happening on this picture. Whenever the ventricle expands and then it contracts, the ventricle is pushing blood into the aorta. So this shows the aortic semilunar valve. Now, if you remember, let's just do a little review. When does the aortic semilunar valve open? The aortic semilunar valve opens whenever pressure inside of the ventricle is higher than pressure inside of the aorta. So once that valve opens, blood is ejected and goes into the aorta. And as blood flows into the aorta, the walls of the aorta are going to expand, which is creating all kinds of potential energy from the elastic component of the blood vessel wall. So as the blood enters into the aorta, the walls expand, creating higher and higher pressure. Well, once the pressure inside of the ventricle is lower than the pressure inside of the aorta, then the aortic semilunar valve closes, and now the ventricle is allowed to go into diastole, where it will fill with blood from the atrium. The walls of the aorta are going to contract. They're going to push blood forward because it creates that pressure gradient, and blood is forced from the aorta into other blood vessels. And this is a pretty good picture. It is showing you the difference between the pressures of the ventricle and then the arteries and arterioles and capillaries. Let's look at the big picture. Whenever the ventricle contracts during systole, pressure gets higher, and then as it ejects the blood and goes in the diastole, pressure gets lower. And then it starts to contract, pressure gets higher, and then it's ejected the blood, pressure goes down as it starts to fill. And then as it contracts, pressure gets higher, and then blood goes into the systemic arteries. You'll notice that the pressure inside of the arteries doesn't go as low as it does in the ventricles because it has to maintain a pressure. It has to maintain that pressure in order to create the pressure gradient for the blood to flow. All right, this line that I'm outlining with the red dot shows you the mean arterial pressure. Now, if you were to summarize this picture for me, you would tell me that what this is showing is that as blood flows through the arteries, arterioles, and the capillaries, pressure gets lower and lower and lower until at its lowest when it gets right before it enters into the right atrium. This picture here is just showing you how we take a measurement of the blood pressure. You take the blood pressure cuff. This whole apparatus is called the sphygmomanometer. You take the blood pressure cuff and you completely surround it on the arm. The arm is from the shoulder to the elbow. And what you're going to do is totally occlude the brachial artery. The brachial artery is the main artery in the arm. So as you pump the bulb, it increases the pressure of the air inside of the blood pressure cuff. The pressure gets higher and higher and higher until the brachial artery is completely closed off. You cannot hear any sounds through your stethoscope. You take the stethoscope and you put it over the radial artery, and you're going to listen for the heartbeat. If the vessel is completely occluded, there's no blood flowing through it, and you cannot hear any type of heartbeat. So then you start letting pressure off of the bulb. The air pressure starts exiting from the inflatable cuff, and as you take pressure off, the artery starts to open again, and then you can hear the heartbeat again in the radial artery. As soon as you can hear the blood flowing through the artery, whenever you start hearing the pulse or the heartbeat, that represents the systolic pressure. So you keep letting pressure off of the cuff. Air keeps escaping from the inflatable cuff until eventually the blood vessel is completely open. And once the blood vessel is completely open, you can't hear the heartbeat again. And then you take another reading, and that represents the diastolic pressure. There is a very important formula on this picture, and it's right here. The mean arterial pressure is proportional to cardiac output times the resistance in the arterioles. Now, for some reason, when I uploaded this PowerPoint onto the program I'm using to record this lecture, it didn't show the little symbols on here. So I'm going to try to draw it in as well as I can. It kind of looks like that. So mean arterial pressure is related or proportional to cardiac output times resistance of the arterioles. Now, what does this mean exactly? That means as one increases, then the pressure increases. For example, as cardiac output increases and the resistance in the arterioles does not change, then the mean arterial pressure will increase as well. Now let's look at this in a different way. What if we increase the resistance of the arterioles without changing cardiac output? Then that means that the mean arterial pressure will also go up. So two different ways to increase your mean arterial pressure, which is basically saying increasing your blood pressure. Either increasing the cardiac output or increase resistance. How do you increase resistance in arterioles? You do it by vasoconstriction. So constricting the arterioles will increase the pressure. All right, let's look at this in another way again. What happens if we increase resistance? However, we don't want to change the blood pressure. If something happens that increases the resistance, then the coping mechanism is to decrease the cardiac output. So if we increase resistance and decrease the cardiac output, then the mean arterial pressure stays the same. This is a pretty good chart to look at, things that determine the mean arterial pressure. If we look at blood volume, how does blood volume affect the blood pressure? It has to do with your fluid intake, fluid loss. Basically, blood volume affects your blood pressure. An increase in blood volume will increase the blood pressure. So how does the heart rate and the stroke volume, how does it affect blood pressure? If heart rate goes up or if stroke volume goes up, then blood pressure goes up. What is stroke volume? Stroke volume is the amount of blood that's ejected during systole. And to find the stroke volume, as a review, you take the end diastolic volume, which is the amount of blood that's in the ventricle right before it contracts, and you subtract the end systolic volume, which is the amount that's still left in the ventricle after it contracts, and that gives you the stroke volume. You got to know the difference between stroke volume and cardiac output for the exam. I'm just letting you know now. Okay, let's look at resistance. How does resistance to blood flow affect blood pressure? As the resistance to flow increases, so does the pressure. All right, let's look at this picture because it's a really good picture. How does the body compensate for an increase in the blood volume? Whenever there's an increase in the blood volume, then there's an increase in the blood pressure. So what are the coping mechanisms or compensation for an increase in blood pressure? We can either use the kidneys or use the cardiovascular system. We'll look at the cardiovascular system left, which is over here on the left. All right, compensation by the cardiovascular system. If there's an increase in blood pressure, vasodilation will be stimulated, and also a decrease in cardiac output. Well, why vasodilation? Because it has to do with resistance. If we remember, mean arterial pressure is proportional to cardiac output times resistance. So vasodilation, again, has to do with resistance. So vasodilation decreases resistance, which will decrease pressure. Decreasing cardiac output will decrease pressure. And then we look at the slower response, which has to do with the urinary system, the kidneys. We'll look at that in Unit 4. So how do the kidneys compensate for an increase in blood volume with an increase in blood pressure? Well, the kidneys will excrete more fluid from the urine, which will decrease the blood volume, and then again, it will decrease your blood pressure. Kidneys is going to be a much slower response compared to the cardiovascular system. So whenever it comes to blood volume and blood pressure, the fastest response or compensation for the body is to use the cardiovascular system. This section talks about how is resistance in the arterioles influenced? How is it controlled? We either use local or systemic mechanisms. Local control, that means at a tissue level. Certain, the chemoreceptors in the tissues that measure the amount of oxygen and carbon dioxide in certain tissues will control how much blood flows to the area. If there's been an increase in carbon dioxide and decrease in oxygen to certain tissues, then the blood vessels will automatically vasodilate to increase the blood flow to that area. Then we have some sympathetic nervous system reflexes, and then using hormones like norepinephrine and epinephrine will vasoconstrict or vasodilate the arterioles. All right, myogenic autoregulation, that just means that the sensors in the blood vessels, as they expand with blood pressure, then it automatically contracts and keeps that pressure in check, keeps it under control. And it has to do with how smooth muscle contracts. Whenever the smooth muscle is stretched, it opens up the calcium channels, and calcium goes into the cell. The more calcium available in the cell, then the stronger the contraction. And then we have some paracrine signals. I think the only thing I really want to mention about that, we're going to look at active hyperemia and reactive hyperemia. All right, active hyperemia, that is whenever there is an increased blood flow to the area and is due to, it has to do with an increase in the tissue metabolism, like an increase in the amount of glucose being broken down aerobically. So we use more oxygen, create more carbon dioxide. So if there's been an increase in tissue metabolism, it will cause vasodilation of the blood vessels, which will increase the blood flow to that area so that we can bring more oxygen to those tissues and we can flush out the excess of carbon dioxide because of the extra tissue metabolism. And then we have reactive hyperemia right here. Instead of metabolism being increased, there's some sort of occlusion. There's a blockage in the blood vessel. Whenever there's a blockage in the blood vessel, then all the tissues beyond that blockage are being deprived of oxygen. They're using the oxygen that's already available, and their carbon dioxide stores are building up because there's nothing removing the carbon dioxide from the tissues. So when there's been an occlusion, it causes blockage, carbon dioxide levels go up, which is going to cause vasodilation. Now the blockage itself, whenever the vessel's been vasodilated, there's more blood flow to that area, and eventually the blockage is removed. And once the blockage is removed, then the blood flow is restored, which will flush out the carbon dioxide, and then the tissues will go back down to normal. So that's the difference between reactive and active hyperemia. On this slide, I just want to point out that the sympathetic nervous system is the part of the autonomic nervous system that's in control most of the time of your blood vessel diameter. So the sympathetic nervous system constantly monitors the tone of the blood vessel walls and constantly sends signals to the medulla. The medulla is where we have the cardiovascular vasomotor center that controls the diameter of blood vessels. So let's look at this next picture. All right, in this picture that we can see, the sympathetic nervous system is controlling or monitoring your blood vessels. It sends the neurotransmitter norepinephrine to the receptor on the blood vessel wall, and it sends a constant signal, which means these are tonic receptors, not phasic receptors, but tonic receptors, and they send a constant signal to the receptor. If the amount of norepinephrine increases, it creates a stronger signal, and it causes vasoconstriction, a constriction of the blood vessel, so it narrows the opening to the blood vessel. If it decreases the amount of norepinephrine being released, that decreases the amount of action potential that happens at the receptor, and it causes vasodilation. And this has to do with the type of receptors, the alpha receptors. Well, if the alpha receptors are stimulated more, it causes vasoconstriction. If they're not stimulated as much, then it causes vasodilation. So which tissues are going to constrict or dilate with norepinephrine? And you have to think about it. If you think about the sympathetic nervous system, where does blood go if you're in a fight or flight mode? Blood is diverted from the digestive organs. Okay, this next section talks about the distribution of blood to the tissues. Whether you're in the sympathetic nervous system mode or the parasympathetic nervous system mode, there are certain things that have to stay constant. The blood flow to your brain has to stay constant because the neurons have a high metabolism. They need a constant supply of glucose, and they also need a constant supply of oxygen. Let's look at this picture. This picture represents your circulation as it goes through each area, as it goes through the brain, as it goes through the heart, the liver and digestive tract, the kidneys, so on and so forth, all of these different organs. You have about 5 liters of blood in your system, and what this is telling you that 14% of your circulation goes to your brain. 4% of the blood goes through to the heart muscle. 27% of the blood goes to your liver and digestive tract. And if we look at these numbers, that is the highest percentage of blood. So would you assume that this person's in the sympathetic or the parasympathetic nervous system mode? It would be in the parasympathetic nervous system mode, because if it was sympathetic nervous system, then blood would be diverted away from the digestive organs. So let's continue down the line. 20% of your blood goes into your kidneys. 21% goes to the skeletal muscle. 5% goes to your skin, and then 9% to your to your bone and other tissues. Now, if we switch to the sympathetic nervous system mode, then the skeletal muscle percentage is going to go way up, and the digestive system would go, and the amount going to the digestive system would go a lot lower. Let's look at the concept in this picture. If we have 4 liters of blood going into a system of 4 arterioles, then the blood that's going into the blood vessels, as long as the diameters are the same in each blood vessel, then it's going to be split evenly. So we had 4 liters going into the system with 4 liters coming out, but we have 1 liter coming through each arteriole. Now, let's look at what happens if one of those blood vessels is constricted. Vessel B in this picture has been constricted, so now it has less blood going through it. We still have 4 liters of blood going in, but now the amount of blood coming out is only 1/4 of a liter. The other blood vessels will compensate, so there will be more blood coming through the vessel A, more blood coming through vessel C, more blood coming through vessel D. So vessel B may be vasoconstricted, but then A, C, and blood vessel D will be vasodilated, so that the amount of blood going through this system stays the same. Let's talk a little bit about the cardiovascular control center. The cardiovascular control center is located in the medulla. That's why it's called the medullary cardiovascular control center. We have sensors located in the carotid and the aorta. These are baroreceptors because they're measuring your blood pressure. They send constant signals to your medulla, and it's telling it what your blood pressure is. All right, let's look at this. If there's been an increase in your blood pressure, which is what we're showing up here, if there's been an increase in your blood pressure, what does that do? That increases the firing rate of the baroreceptors. That means your blood pressure has gone up. So then medulla interprets that as a higher than normal blood pressure. There are 2 different things the medulla can do to lower your blood pressure. It's going to either stimulate the parasympathetic nervous system, or it's going to decrease the sympathetic nervous system control. So let's start with the parasympathetic nervous system. The parasympathetic nervous system, what is it going to do? It's going to inhibit the SA node. Well, how does it inhibit the SA node? If we go back to the chapter 14 PowerPoint, it says that it hyperpolarizes the SA node. But how does it hyperpolarize the SA node? By opening the potassium channels. As the potassium channels open, we lose a positive charge and it hyperpolarizes the SA node, so it's harder to fire and it slows down the heart rate. So stimulating the parasympathetic nervous system will slow the heart rate, which will then decrease the cardiac output and then decrease your blood pressure. Now let's look at the left side of this chart. How do we decrease your blood pressure? By decreasing the sympathetic nervous system. Well, if we decrease the effect of the sympathetic nervous system, it causes vasodilation of your blood vessels. It causes a decrease in the contraction of the ventricle, and it also decreases your heart rate if you decrease the sympathetic nervous system. Well, decreasing vasodilation will decrease resistance, which then will decrease your blood pressure. And this goes back to the mean arterial pressure is proportional to cardiac output times resistance. So lowering resistance lowers the mean arterial pressure. Let's write that formula on this slide. So mean arterial pressure is proportional to cardiac output times resistance. All right, let's look at this picture. As blood leaves through the left ventricle, it goes into the arteries. Then it goes into the arterioles, and the arterioles are the variable resistance vessels. We looked at that in the very first slide. So let's look what's happening here. What happens if we vasoconstrict one of these blood vessels? If we constrict arteriole A, well, whenever you constrict a blood vessel, it increases the resistance. What happens whenever you increase the total resistance? If we go back up here to this chart, if we increase resistance, then it increases the mean arterial pressure. So that's what they're showing here. If we increase resistance and it multiplies by cardiac output, then it increases the mean arterial pressure. Well, we don't want the arterial pressure to go up. So what is the compensation? Well, according to the baroreceptor reflex, one of the things we're going to do is decrease the sympathetic nervous system response or increase the parasympathetic nervous system response. So what does that mean? That means we need to lower the cardiac output. If we lower the cardiac output, then we don't change the mean arterial pressure. So increase in resistance in blood vessels, and if we lower the cardiac output from the heart, then it keeps the mean arterial pressure the same. Let's start talking about exchange at the capillaries. But first, let's review a little anatomy of the capillaries. There are three types of capillaries. There are continuous capillaries, there are fenestrated capillaries, and then there are sinusoids as well. The continuous capillaries are the most common of the capillaries. They're also the least permeable capillaries. We find continuous capillaries in the skin and also in the skeletal muscles. I say they're the least permeable because the only way for there to be an exchange in continuous capillaries is either between the cells or through the cells through transcytosis. So either the paracellular pathway or they're using transcytosis. The fenestrated capillaries are more permeable than the continuous capillaries because not only do they have gaps in between the cells for paracellular pathways, there's also holes in the cells, which is what fenestrations are. So now we can lose or exchange nutrients through the holes of the capillaries as well as between the cells of the capillaries. And then the sinusoids are the most permeable of the capillaries. The gaps between cells are huge. The fenestrations in the cells are huge. It allows whole cells to pass through the walls of the sinusoids. We find sinusoids in the spleen, which makes sense because that's where red blood cells go after they're no longer useful. The spleen will break down the red blood cell. We can reuse and recycle part of it, and the rest of it we're going to get rid of as a waste at some point. We also find sinusoids in the liver, which makes sense because the liver makes your plasma proteins. Plasma proteins are rather large, so they have to be able to be inserted into the circulation. So liver has sinusoid capillaries. And then we also find sinusoids in bone marrow, which makes sense because your red blood cells and your white blood cells are made in the bone marrow and has to be put into the circulation somehow, so it's through the sinusoids. All right, let's look at this picture showing the continuous capillaries and also the fenestrated capillaries. Continuous capillaries are on the left, fenestrated capillaries are on the right. There are gaps in between the cells. They're called intercellular clefts, and we can see them right here. We can also see them right here. And the fenestrated capillaries on the right, they also have holes in between the cells. That's what the fenestrations are. So remember, whenever fluid passes between the cells, that's called the pericellular pathway. If it goes through the cell, starting at one side, the apical surface, and ends through the basolateral surface, or through one side of the vessel to the other, it's called transcytosis through the cell, which is what we also do with the fenestrations. There are some important concepts on this slide. It has to do with the velocity of the blood flow. Remember, there's a difference between flow rate and velocity. The important point on this slide is that the velocity of flow is higher in smaller diameter tubes. If we can remember back to chapter 14 when we talked about velocity in the chapter on the heart, there was a formula. The formula was V equals, we had a Q over A. The V stood for velocity, Q stood for flow rate, and then the A, that stood for the total cross-sectional area. All right, let's see how this formula works. I'm going to try to erase my arrows. All right, if we want to see how this formula works, if we increase the flow rate, then it increases the volume. All right, that much we can understand. But then what happens with the area? If the total cross-sectional area increases, what does that do to velocity? It decreases the velocity. So what does that mean? That means vessels with a smaller diameter have a slower velocity. That's the garden hose example that I used when we talked about this in chapter 14. If you take a garden hose, turn the water on, and you put your thumb over the end of the garden hose, what does that do to the water? It makes the water come out faster, and then it can go further if you're trying to water something across the yard instead of walking over there. Now, the capillaries, ironically, have the slowest flow. And you would think, well, the velocity of through one small vessel should be faster than a larger vessel because of this whole formula that we just went over. But whenever you look at capillaries going to an organ, you have to take all of the capillaries into account. For example, there are thousands of capillaries that go to one organ, hundreds or thousands of capillaries to this one organ. You have to take all of that into consideration when you're looking at the total cross-sectional area. This is an awesome picture showing you the velocity of the flow of blood as it goes through our system. It shows that the velocity of the blood as it goes through the aorta is really high, and then as we get to smaller vessels, it starts to get lower. And then the lowest velocity is through the capillaries, and then it goes back higher as when the vessels get larger. Now this bottom picture shows you the total cross-sectional area. So the total cross-sectional area of the big vessels is small, and then we get to the capillaries, it grows because we're talking about all the capillaries at once. And then as we get to smaller vessels and to larger vessels, the total cross-sectional area will decrease. Now, what is the point of this? This is just to show you that the velocity of blood through the capillaries it has to be slower so that we can exchange as much things as possible. So we can exchange the maximum amount of glucose to the tissues, that we can exchange the maximum amount of oxygen and carbon dioxide that we need to as we pass through these smaller diameter vessels. This is a good picture showing you the difference between one strand of spaghetti and a whole bunch of spaghetti. If you were to take the one strand to represent one capillary, then the velocity of blood going through that one capillary would be high. However, if you take the total cross-sectional area, which would represent all of the capillaries going to one organ, the area of all the vessels is a lot larger than the area inside of one capillary. So that means the velocity will be slower with the total cross-sectional area. This next section is actually a pretty important section, and the picture that's next on this slide is actually pretty important. We're going to look at the difference between filtration and absorption when it comes to the capillary bed. Now, whenever we look at the picture of the capillary bed, there's going to be two ends. There's going to be an arterial end, and then there's going to be a venular end. The arterial end means it's coming from the systemic arteries, and the venular end means it's going into the systemic venules. Let's look at the definition of filtration and the definition of absorption. I'm going to go ahead and go to the picture. Okay, well, there's this picture showing you the arterial end and then the venular end. We're showing that there's net filtration that occurs at the arterial end and net absorption. What is the definition of filtration? The definition of filtration has to do with where the fluid is going, the pressure. Filtration means we have fluid going from inside the capillary to outside of the capillaries. And then we have net absorption. The direction is the opposite. It starts from the tissues, and net absorption means it goes into the internal environment, into the circulation. This is one of my favorite pictures because you can find all kinds of stuff just on this alone. So let's look at hydrostatic pressure, and then we're going to look at colloid osmotic pressure. If we look at the capillary bed, and we start at the arterial end on this side, and we look at the hydrostatic pressure, the color blue and these arrows showing you filtration and the hydrostatic pressure. Hydrostatic pressure is when you go from high pressure to low pressure, going from inside the capillary to outside of the capillary. When we start at the arterial end of the capillary bed, hydrostatic pressure is at 32 millimeters of mercury. The exact number does not matter, but the concept does. If it starts at 32 at the arterial end, as it loses fluid to the tissues outside of the capillary, the pressure gets lower and lower and lower. So filtration pressure starts higher at the arterial end, and then by the time we get to the venular end, it's a lot lower, ending at around 15 millimeters of mercury. Now let's look at colloid osmotic pressure. Colloid osmotic pressure is represented by the red arrow and this red box, which used to have a little omega on it. Who knows why it's not on there. But anyway, if we look at osmotic pressure, it starts at 25 millimeters of mercury and it stays the same. It does not change. So colloid osmotic pressure stays the same. So what does that mean? Osmotic pressure is the force that's bringing fluid back into the circulation. Well, why does it do it? How is it doing that? It has to do with the plasma proteins, like albumin. Albumin is the most common of the plasma proteins and also happens to be the largest. So the more albumin that is present in the blood, the higher the osmotic pressure. Now, what does that have to do with the flow of fluid or water? Water is attracted to areas with higher osmotic pressure because that means it's more concentrated. So water wants to dilute. Water flows to areas where there's a higher concentration of solutes. So we have two forces of pressure. There's filtration pressure, forcing fluid out, and then there's osmotic pressure, forcing fluid back in. Osmotic pressure stays the same because albumin does not change. The amount of albumin does not change, and because it cannot leave the circulation. So at some point in the capillary bed, osmotic pressure is going to be higher than hydrostatic pressure because hydrostatic pressure drops continually as it goes through the capillary bed. So at this point, whenever osmotic pressure is higher than hydrostatic pressure, now we have a net force of bringing fluid back into the circulation. So filtration pressure is higher on the arterial end, filtration pressure is lower on the venular end. Hydrostatic pressure stays the same. However, at the venular end, osmotic pressure is going to be higher than filtration pressure to bring fluid back into the system. If you have any questions about this picture, make sure you email me. I could easily, whenever I made up my own exam, I could easily ask 20 questions just based on this picture. And in lab, as a matter of fact, I probably will. All right, the lymphatic system. The lymphatic system is real easy to understand and is real easy to read. So the only things I want to point out are the functions of the lymphatic system. One of the main functions of the lymphatic system is to return excess fluid back into the circulation. In that previous picture, we saw that we have filtration pressure forcing fluid out of the system, osmotic pressure bringing fluid back in. It's not a perfect system, and there's still going to be some fluid in the tissues. This fluid can be returned back into the system using the lymphatic system. All right, so it returns fluid, and sometimes there are some small proteins that can also leak out into the tissues, and we want to bring those proteins back into our system. We cannot leave the proteins in the tissues because it creates an osmotic pressure in the tissues, and we don't want to do that. And then the other function of the lymphatic system is to absorb fats. We haven't gone over the digestive system yet, but if you can remember back to your anatomy days, there are lymphatic capillaries in the villi of the small intestine. They're called lacteals, and lacteals will absorb fatty acids that have been absorbed from your gut, and then it transports it back into your circulation. Whenever we look at the lymphatic system, the very smallest vessels are called lymph capillaries. The lymph capillaries are closed-ended, which means that it's not open at the end. There are flaps or valves that allow one-way direction of fluid into the lymphatic vessels. Every so often, when we get to the larger lymphatic vessels, they have these bean-shaped organs called lymph nodes. And the lymph nodes are full of cells that are going to clean the lymph. There are cytotoxic T cells that will break down pathogens. There are anti-cancer cells called natural killer cells that will help destroy any type of cancers that might be floating through the system. Then there's also B cells that are going to be located inside of the lymph node as well. It helps clean the lymph so that when it's returned to circulation, there's nothing harmful in it, which is why whenever there's an infection in the system, if you have swollen lymph nodes, it's because it's fighting the infection that entered through the lymph. Now let's talk about edema. Edema is tissue swelling. Whenever there's an accumulation of fluid in the tissues, it's called edema. Now normally the lymphatic system will be able to drain that tissue fluid back into your circulatory system, but if there's some sort of insufficient lymph drainage, then it causes edema, which is swelling. Edema is also caused during inflammation of the tissues due to injury. That has to do with some of the cytokines and hormones that are going to be in that area after an injury. Now let's talk about this picture just a little bit. It's showing what happens to us if we're malnourished. And malnourished means that you're not getting enough nutrients for your cells to use. It happens during starvation. It happens in a lot of different countries. In this picture here, it shows that there's a swollen belly or swollen abdomen showing right here. Well, if they're malnourished, why is their abdomen so swollen? And that's one of the questions on the pre-lab for the capillary filtration case study. It has to do with albumin and your plasma proteins. If you're malnourished and you're not getting enough proteins in the system, then there's not enough for the liver to make the proteins that your tissues need, like the plasma proteins. So if you're missing or deficient in proteins, then the liver will break down your albumin and use the amino acids from the albumin to create other proteins your tissues can use. So if there's not enough albumin in the system, that means there's not enough osmotic pressure to pull fluid back into the circulatory system. And the limbs, there's not a lot of room in the limbs, so that helps to keep the fluid in the cardiovascular system. But in the abdomen, there's a lot of space in between the capillaries. There's a whole bunch of capillaries concentrated just in the abdomen. So they're losing a lot of fluid and not being able to bring that fluid back in, which causes the swollen belly. And that's the end of this chapter. So if you have any questions about chapter 15 when you're looking at the study guide for the exam, please let me know.